All right, welcome to this DEBx medical webinar. We're going to talk today about Debrichem. Debrichem, the topical desiccating agent, a chemical debridement action, and actually its efficacy, efficiency, and effect on healthy skin. Before we start on Debrichem and the healthy skin effect, I want to tell you a little bit about DEBx Medical. DEBx Medical is a company from the Netherlands, located in Amsterdam. It was founded a couple of years ago by a surgeon, a chemist, and a biochemist. And basically with the idea to challenge the world of chronic wounds. Because almost 2% of the whole world population has a chronic wound and is struggling with this disability every day. This daily struggle is actually for those patients very heavy and can actually result into amputation if the wound doesn't heal. And those amputations, they have a lot of mortality risk. Within 5 years, 80% of a major amputation, they even die due to the effects of that. So we need to do something about that, is what they thought. And that's how they developed Debrichem. Today, I'm going to talk to you about that. And my name is Hans-Pieter Snels. I'm the clinical and product director for DEBx Medical. I'm responsible for all the clinical and product work, making sure that we have a good understanding of the clinical role of Debrichem as a chemical debridement. My background is actually in technical medicine. I am an engineering physician. And from this perspective, I'm doing a lot of work on the clinical side for Debrichem, and I love to do it. Today we're going to talk about Debrichem, the topical desiccating agent, and its mode of action. I'm going to explain to you what Debrichem is doing to the wound bed and to the biofilm. And I'm going to explain to you the safety and efficacy of the product. And I'm also going to show you why it's safe on healthy skin to do that. To understand the mode of action of Debrichem a little bit, let's just go back to the beginning a little bit. The beginning is wound healing. We have 4 phases of wound healing. The hemostasis phase, the inflammation phase, the proliferation phase, sometimes also called granulation, and then the remodeling phase, where the epithelialization goes on, where we get a complete coverage of the skin again. And all these 4 phases, they have a lot of materials actually that are cells and all these types of things that are involved in the whole cascade of doing wound healing. And something in this cascade goes wrong, most of the time in that inflammation or proliferation, granulating phase, stalling the process of wound healing, making a wound chronic, making a wound hard to heal, making it even sometimes non-healing. And all those wounds that have an impairment there is what we now know, also commonly know as ulcers, that we define as a diabetic foot ulcer, venous leg ulcer, arterial ulcer, a pressure ulcer, or a post-trauma ulcer. The problem with all these ulcers actually is that something is going on in that whole cascade that is impairing the wound healing, that is stopping the progress. And most of the time we see that it's called a biofilm that's doing that. A biofilm is actually quite common. Biofilm is something that we find in air conditionings, in food processing chains, even in your dental plaques in the mouth or in the water supplies. And the biofilm is actually just some bacteria that move towards an environment where they think that they can thrive. In the clinical reality, actually, a biofilm onto a wound bed looks sometimes not even visible. Sometimes it's that greeny, yellowish, sloughy material that is present. And actually, what we know now is that biofilm with these bacteria inside actually have a bit of a light up, a fluorescence, where you can see that with UV light. So it really emits back some light, and the biofilm will light up, and we can see that. And we need to do something about the biofilm that is causing that infection. To treat the infection and to treat chronic wounds, there is a widely known principle, and this principle is what we call the time principle. The time principle is actually based on the acronym called TIME, basically standing for tissue, infection/inflammation for the I, and moisture balance and edge at the E. Meaning that we need to have the right tissues present in the wound bed for the proper wound healing. We need to challenge and tackle the infection, making sure that the right inflammation reaction is going on. And we need to do that by keeping a right moisture balance. We not have to have a too dry wound bed, and a very moist wound bed is also a very wet wound bed is also not something that we want. So we need to get the right moisture balance in. And then finally we have the E, the edge. That needs to be sharp demarcated, that needs to be clear, because the epithelialization, so the last phase of wound healing, comes from the edges to regrow back over that breach of skin. And when we're talking about infection and biofilm in chronic wounds, this is something that we need to treat. This is something that we need to tackle. So that's actually where we're focusing on the tissue and the infection, the I, the T and the I of time. And we do that by removal of the infection and necrotic tissue to get rid of any barriers that impair the healing. And those barriers, so that necrotic tissue, those biofilms, they actually protect the bacteria that are present and the bacteria that are making sure that wound healing does not progress. So those bacteria, they even contribute to any persisting infection and so on that is present. So we need to get rid of that necrotic tissue. We need to get rid of that infection. We need to get rid of any biofilm. And how do we do that? Well, we do that by debridement. And there are several types of debridement available. We have surgical debridement, and we have sharp debridement. There is hydrosurgical debridement. There is even maggot therapy that we call biosurgery sometimes. And then you have a couple of molecule-based debridement methods like collagenase or bromelain and hydrolysis with wet dressings and so on. Basically, the gold standard at this moment is the surgical debridement. Surgical debridement placed in the operating theater in a sterile environment where you use a scalpel or a curette or any tools to get rid of that necrosis and the biofilm to leave a healthy wound bed to do wound healing. If you don't have any facilities present like that, well, you can also do the same procedure in the outpatient clinic. Sometimes it happens in home care as well, that they scrape out the wound bed with these scalpels or curettage. And then we call it sharp debridement because it's not in a surgical environment. Sometimes in the ambulatory setting or in the surgical room, you can also use hydrosurgery, where you use a water beam, or sometimes even with an ultrasonic beam, to get rid of any necrotic tissue or biofilm in the wound bed area. This is a more high-tech, advanced method of doing debridement. And I was mentioning the maggot therapy as well. So you put maggots in a pouch onto the wound bed. It's quite pricey method because you need to have sterile maggots that are still alive to eat away the necrotic tissue. And that's actually the only thing that the maggots do. They eat away the necrotic tissue. So they are quite efficient in getting the necrotic tissue out of that wound bed area. But there is some psychological issues to putting maggots on a wound bed, as you can imagine. And then you have a couple of more slower aspects where you need to have some time, and it's called enzymatic debridement, for example. You can do that via collagenase, bromelain materials, and those are infused in dressings or creams that you put on the wound bed. And then with the next dressing change, you change that, and then you will gradually, over time, the infection will reduce, the biofilm will reduce, and sometimes it doesn't even have any effect. That can happen. And now we are talking about chemical debridement with Debrichem. And basically, the topical desiccating agent Debrichem removes necrotic tissues and biofilm by breaking open the biofilm, by capturing water, dehydrating the wound bed. The chemical debridement is a much faster, because you use it only 1 minute, and then you rinse it off with some saline. So it's a much faster way of debriding than, for example, surgical debridement, depending on the size of the wound, of course. And the pain sensation with a chemical debridement, while using an acid, for example, is quite similar to the one of a surgical debridement. Debrichem is also one that you only use one time in the whole treatment process of a wound. So you use it one time for 60 seconds. You do not have to repeat it after a week. You do not have to repeat it after 2 weeks. You get rid of the biofilm in one treatment. And now you think, how does that work? Well, we have actually a nice video to show you the mode of action. And I will run you through that video, because it's important to know that most of these wounds, they have that biofilm infection that come from the bacteria that are planktonic, free-floating bacteria. They actually find a wound a very nice environment to thrive. So they settle in, they start to multiply themselves, and then grow a house for themselves, which we call an extracellular matrix. That is actually a quite strong structure where they can thrive and proliferate and do things and communicate to each other. However, the biofilm has a lot of water content in it. So it's built up out of a lot of water. 95 to 97% of water is actually in there. And the rest is just some sugars and proteins. And now the Debrichem is a chemical debridement that reacts with water. So you see what happens there, reacting with the water in the biofilm. Debrichem's methanesulfonic acid binds with the water molecules in that biofilm, in that wound bed. So it's dehydrating it very fast in 60 seconds. That dehydrating actually releases a lot of energy as well. And that energy release causes even other aspects to happen. But first, the dehydrating is the most important part, what happens, because you capture the water molecules, making an environment for those bacteria that they cannot live anymore. And the energy release that we see is actually also unfolding these protein structures, breaking down molecular bonds, making these functions of those molecules also gone. So there is actually a disruption of the whole biofilm structure, dehydrating the aspects of the wound bed area, making a complete wasteland where bacteria cannot live anymore. And this is actually what happens within Debrichem. So that's the most important part to understand and to follow. That is dehydrating. That breaking down molecules is actually quite interesting to understand, because that is also what happens and what you see in a clinical visual effect after using Debrichem. So you use it for 60 seconds on the wound bed, and then you rinse it off, but the wound bed physically changes visibly. So it's really dried out in a superficial layer. So it's a desiccated, dehydrated plaque on top. And you can really see that after the application. So talking about the application, we have a nice video on that as well, to give you a bit of an idea on what to do during that application. But this video will also show you what I'm meaning with that color change, that visible change during and after the treatment of Debrichem. So when you have Debrichem, you first get your patient into your practice on your ambulatory setting, as in this movie, have the patient on the treatment table, and then you prepare your working area. You get your gloves out, your nitrile, polyethylene, polypropylene gloves, whichever medical gloves you have available. Then you remove the dressing from the patient, from the wound bed area, and you do the inspection, of course, and the thorough cleaning as you would normally do with any dressing change. Making sure that you have any loosened debris that is there, you remove that. Then you dry out the wound bed area with some gauzes, making sure that you still work in a clean way to do it. So you take on some new gloves, for example, and then you put on a topical anesthetic. We normally use an EMLA cream of 5%, leave it on for 20 minutes, and that will do the trick for numbing the effect of Debrichem. As you would do this also when you have, for example, a sharp debridement, because that is a bit the same in the level of pain that we can expect with the patients. Then you pour, after you have taken off the EMLA cream, pour Debrichem onto the wound bed, onto the edges of the wound bed, and also on the peri-wound area, as you can see very well in the video. And then you leave it on for 60 seconds, making sure you have the saline at hand or sterile water, and you start rinsing it off. And then you already see underneath that red gel, that Debrichem, that the wound bed really changed, but that the intact skin surrounding that is still nicely intact and not affected. Then you dry the wound bed, making sure that you get every loose debris out, and then you put a dressing on, whichever is suitable for that type of wound. In this case, it was a venous leg ulcer, so we put on a absorbative dressing on there, and then a compression therapy to make sure that the venous insufficiency is covered as well. Just to recap a little bit on that mode of action, the visible effect of Debrichem is something that really happens. And this is something that we, of course, have to prepare the expectations of our patients with, because their wound will change after 1 minute application. However, this is to the benefit of the wound healing process. Because what happens is, with this case, for example, is that it's completely dehydrated. You see a big color change, it's a bit grayish, brownish. And this desiccated plaque we left on there, and then on that desiccated plaque we put on the foam for the negative pressure therapy, for example. And after 1 week, the wound bed was fully granulated. Then we grafted, 100% successful graft was on there, and the wound moved towards complete healing. Actually, after 3 days with the first dressing change of the negative pressure, we already saw a nice granulation going on, and the desiccated plaque, the dehydrated plaque, was just sloughing off easily. And then the rest of the desiccated plaque that was still on there, we just put a new foam dressing on for the negative pressure to do its trick. And then after 1 week, we had full granulation. And as you can see in that video, it was in an ambulatory setting where you just simply clean the wound bed, pour Debrichem, the red gel, on there, and then rinse it off. It's quite versatile to be used. You can use it in any setting. So you can use it in an ambulatory setting, but you can also use it in the surgical theater if it would allow, or even in the home care setting. So it has multiple applications from where you can use the product. So from the mode of action and how to use it, this webinar is considering the effect of Debrichem on the healthy skin and its efficacy on the wound bed area. We have done some in vitro work on 3 biofilm models in Australia. And these 3 biofilm models were inflicted with a biofilm culture of Pseudomonas and MRSA. So we actually have 6 models with different species going on, where we used Debrichem on those biofilm models. And then we took some electronic microscopic images to see what happened to those biofilms. And what we saw is that there was complete eradication in the electronic microscopic images, and also from the counting of the bacterial areas in the biofilm models, we saw complete eradication. There was no regrowth whatsoever in the whole biofilm model. This was quite astonishing for the performance to show in the in vitro models of biofilm. So we thought, what does that do on the human skin? So we asked NAMSA, organization in the United States of America, to use a human explant model. So we took a piece of human skin where we inflicted a biofilm on. We inflicted first of all a wound, then a biofilm, and we matured that biofilm, and then we treated it with Debrichem. We saw something funny there as well. Actually quite astonishing funny as well. But first, let me just explain to you what we can see, because we made some histological pictures on that. In this first picture, it's an untreated and uninfected histological frame. And you can see on the top and the bottom side, there is a dark purple area. And this is actually the top skin layer. So the epithelialized cells of the skin layer. And you see that there is a breach in the middle. This breach goes a little bit deeper, and that's actually the wound that we inflicted on the human explant model. So basically, this is an uninfected, untreated histological image. And what we then did is put a biofilm on there. And in the next frame, you can see a histological image of a biofilm in that wound area. So you see on the left bottom side of that image still that dark purple area, which is the epithelialized layer of the skin. But you can also see bright, darker dots. That is indicated as biofilm on this picture. And you see that it's really infiltrating in the human cell layers in that wound area. So this is a frame where you can see it's an untreated but infected histological image. You can really see it's really disrupting the whole cell layers and structure compared to the one that we just now saw from the untreated and uninfected histological frame. So we made biofilms out of 3 different types of bacteria. So the Baumani bacteria, the Pseudomonas bacteria, and MRSA bacteria. We matured them for about 72 hours. So we had a nice mature biofilm in those human explant models. And then we treated those for 30 seconds, 1 minute, and 5 minutes with Debrichem. From the performance perspective, we saw that actually in all these models, there was no regrowth of biofilm whatsoever. And this was quite astonishing to see, that even after 30 seconds, there was no regrowth of biofilm. And there was, in the 5 minutes exposure of Debrichem, the detachment of biofilm was even stronger than the ones in the 1 minute or the 30 seconds. So there was a lot of the dark spots of biofilm that we saw on the infected frame of the histological image. We see them as well in the treated image for 5 minutes. It's indicated with an arrow with biofilm as well. But those are completely dead. Those bacteria are dead and they do not regrow. And we already see a lot less biofilm cells present, biofilm spots present, because they already detached from that wound area that was on there. Then we thought, let's have a look at the safety aspect. So we compared the cytological aspects, the morphological aspects, and the histological aspects of the human cells underneath that biofilm, and the human cells that also were in touch with the Debrichem application. And what we noticed there is that there was actually no change towards any of the cells from the human side. So there was no change in any cytological aspect or histological aspect. And for the sharp eye, you can see that in this frame as well, that in the top side, there is the human cells present, and there is all these nuclei of the cells still present. So there is a nice human explant still viable in that area. And this was actually quite astonishing for us to see, because after 5 minutes, there was no effect on the human cells. And actually, this confirms also what we saw in the video on the application, that the healthy skin, the intact skin surrounding the wound bed area that was treated in the peri-wound aspect, was not affected by Debrichem. So basically concluding that Debrichem is very, very safe on these chronic infected wounds with biofilm. And I want to also show you this from the clinical perspective. We were talking about biofilm infection. We saw this in the in vitro aspect, in the in vitro aspect on human explants. But from a clinical aspect, I have here a case that I want to show you. It's a diabetic foot ulcer of a 64-year-old male. We treated in Italy. And the doctor there also had the Moleculite device present. For those who are not familiar with Moleculite, it's a device, it's a camera that takes pictures from the wound, but has a possibility to send out ultraviolet light as well. And this ultraviolet light, as I indicated in the beginning of the webinar, shows up fluorescence of the bacteria present in the wound bed. And there is artificial intelligence in the device of the Moleculite that actually analyzes how much bacteria are present in that wound bed area. And this diabetic foot ulcer actually is an amputated first digit of the right foot. And this amputated site got infected. It did not progress to healing. You can see it's a bit yellowish. There is some red spots in there, but it's not looking very healthy as a wound bed. So what we did, we treated it with Debrichem for 1 minute and then rinsed it off, use some sterile gauzes to dry and clean it, clean any debris that is loosened. So you can see that there's already quite sharp demarcations on the edge and that there is quite a significant change visibly on that wound bed area of this amputated site. And we did this picture as well with the Moleculite device. And we saw the biofilm model in Australia and the biofilm model in the human explant, that we completely eradicate that aspect. And with the Moleculite device, we can show these bacteria that are present on the wound bed area. And you can see that in this picture, that it's really lighting up, bright, greenish, white even, lighting in the wound bed. But the more interesting part is even that circular red area on the edges and a little bit in the peri-wound area of the wound bed. And that is really a big indication of a strong infection of bacteria that are there. And basically that red fiery ring that is fluorescent in this picture is very difficult to remove when doing a sharp debridement. We understand from the Moleculite device team that this red fluorescence is actually almost impossible to remove. There is always something left when you do a sharp surgical debridement. And now look at this picture when we have treated this wound with Debrichem. You can see that the whole red illuminescence, fluorescence is completely gone. And that the bright white spots inside the wound bed are also gone. There is still some fluorescence going on, but this is basically the callus and some dead skin cells that light up as well within the fluorescence. And the artificial intelligence within the Moleculite device will tell you that this is not a bacteria infection anymore. So basically in 60 seconds, we see a complete removal of the fluorescence of bacterial load in this wound bed. And we also saw that in the in vitro area of the human explant, and showing also that the intact skin is very untouched and actually quite cleaned from any bacterial load that might be present. And then after 1 week, we saw nice granulation already going on. After 1 month, the wound bed was already for 75% epithelialized, and after 2 months, we did not hear anything back from the patient because there was nothing to report back. So basically, talking about Debrichem, we saw now that it was quite safe on the intact skin, and we saw that there is no effect in the histological images underneath that biofilm in any wounds. And doing this by the steps of using Debrichem, by pouring it on the wound bed, making sure that you cover the whole wound bed making sure that you cover the edges and the peri-wound area, and then after 1 minute rinsing it off with saline or sterile water, but making sure that in the preparational side, you use your protective gear as your gloves and maybe some amla cream if there is some pain sensation that needs to be managed. And then afterwards, any dressing that would be indicated for these patients can be used, as Debrichem is completely neutralized by rinsing it off with the saline or the sterile water. So for example, in the diabetic foot case that we saw, we put on a hydrogel and then used an offloading to do the proper wound healing and promote that. And for example, in the video of the case where we saw the application process, we used a compression to make sure that we cover the venous insufficiency, and we use absorbative dressing for any remnant exudate that might be present there. Then just a couple of pointers as we're reaching the end of the webinar already, is that Debrichem is a chemical debridement for the soft tissues. We can get rid of any infection and biofilm in the soft tissue, so if there is any bone or bone infection present, this is something that we cannot treat with Debrichem. So be careful with osteomyelitis, because that is something that you need to discuss with your multidisciplinary team on how to approach the osteomyelitis, but debridement of the soft tissues might be possible with Debrichem. If there is any tendon, cartilage, bone present, this is also something to be careful of. Any abscesses or fasciitis needs to be resolved first as well. So please cover this with your multidisciplinary team to search for the best approach and to have the most optimal approach and outcome for your patient. And of course, to do proper wound healing, we need to have some blood circulation in the wound bed area. So any ischemic ulcers would be contraindicated for Debrichem, because there is no wound healing that we can promote, and there is no possibility to do a wound healing in whatsoever. So a revascularization might be very interesting to do there. And then maybe we can use Debrichem to get rid of any infection that might be left. And then the last point I wanted to point out is that we talked a little bit about the pain sensation that Debrichem can cause. It is basically equal to the pain sensation that we have with sharp debridement. So please cover this as well with a topical anesthetic, as you would normally consider also with the sharp debridement, and then you would be able to treat most of your patients, but always keep your patient in mind and the sensory sensitivity of the patient. Keep it in mind, because the patient will indicate the pain level, and that is something that you need to cover. And if it's too unbearable for the patient even to touch the wound, you might maybe want to consider a nerve block instead of an amla cream. So please cover this as well with your team, and make sure that you always keep the patient as the point of center of the attention. Thank you for paying attention to this webinar. Thank you for listening in. I hope you have learned a little bit about the safety aspects and the healthy aspects. And now we'll move towards some questions that we will do and answer for you that will come in. So a question is coming in on what is the type of wounds there Debrichem is the most effective. Well, basically any wound that is infected and that is not progressing to heal needs a debridement. And then a chemical debridement with Debrichem is very effective to do that. Of course, we need to keep a little bit in mind what the contraindications are of the product. So any ischemic ulcer is very difficult to heal. So basically, that is contraindicated. Maybe we need to do a revascularization first, so there's a multidisciplinary approach needed. We need to be careful with any materials that are made out of the harder materials are present, so tendon, cartilage, bone. It needs to be discussed and covered, because we need to make sure, if we need to have any functionality left of those areas, that the orthopedic surgeons are involved. So make sure that the multidisciplinary team is involved, but mostly What's important is that when the wound is an infected wound that is not progressing, like a diabetic foot ulcer, like a venous leg ulcer, like a pressure ulcer, like an arterial ulcer, they are all possible and indicated for Debrichem to be treated as with the chemical debridement. All right, the next question coming in is, can I use Debrichem myself? Well, the answer is simple, yes. We can help you out in setting up a demonstration. If you go to our website, you can submit your request for a free demonstration. And what we will do is we will help you out selecting a couple of cases. Best would be 3 to 5 cases with different types of wounds, so that you can experience on all these types of wounds what Debrichem is doing and see what Debrichem is doing in the follow-up as well. And we will make sure that we arrange that with you. We will assess the cases with you if they are most suitable for you at that point. And then we will get you in touch with our local partner that will come to you and will provide you with Debrichem and will help you out in that day of treating those 3 to 5 cases. A question coming in on what do you have in patient experience? Is there any experience for patients and what did they think about Debrichem, the topical desiccating agent? Well, basically, the treatment itself can impose a little bit of discomfort for these patients. And that's actually what they mentioned as well, that yes, sometimes they feel that burning sensation of Debrichem as it's based upon an acid and they notice that. They do say it's only 60 seconds, it's only 1 minute, and that's quite easy because if my doctor would do a sharp debridement, they might sometimes be busy for 15 minutes and it would be still an agony of pain during those 15 minutes. So that 1 minute is quite fine. And we have also had a lot of reports already on that patients with chronic wound pain, that chronic wound pain actually dissipates over the course of the first couple of days, and that they actually get much more comfortable with their wound and being able to join in their social life again. We even had one patient that came back to us and said, well, I was even able to go to the pub yesterday evening. So that gives it that they actually have a unburdening of their chronic wound problems, and that they would happily have a little bit of discomfort during their wound dressing and during their debridement. Another question that come in is how to implement Debrichem in my treatment protocols. What's a difficult question because it's basically policy making, but it's an easy answer for us in the sense of Debrichem is part of your wound care toolkit. You can use Debrichem whenever you find your wound to be infected and in need of any debridement. So when imagine a patient comes in, you see them for the first time, you see that the wound is already there for 6 weeks, the patient tells you that, and you see that it's quite oozing, a lot of slough in there, and it's not in a good state. You would clean it with your wound washing, and you would clean it with your gauzes, and you would have an assessment on it, and you are for sure there is a biofilm present. You can use Debrichem, treat it, make sure that you get rid of any infection, any biofilm present there, and then dress it as you would normally do with that type of wound that just walked in, and then send them home and get them back in the next 3 days and just do the reassessment. And there is already a lot going on in progressing of that wound. So basically, just see it as an added tool to your toolkit that you can use whenever you find the wound to be infected and in need of a debridement. Then another question is, how much wound can I treat with 1 bottle of Debrichem, for example? So 1 bottle of Debrichem has about 3 milliliters, 3 milliliters of gel, and this is enough to cover about 10 by 10 centimeters in theory. And in practice, we see that sometimes it can be a little bit more than that. So it's quite a large surface that you can treat with the 3 milliliters of Debrichem. And just to make sure that you rinse it off after 1 minute with ample of saline or sterile water that you have. And people, well, thank you very much for paying attention. As we're running up to the end of the webinar timing, I want to thank you all for paying attention, for your lovely questions. If you have any questions that are unanswered, please feel free to put them in the chat. We will keep on answering a couple of the questions there. You can always submit a question on our website or send us an email. And we will keep those topics in mind for our next webinars. So please stay tuned as we will do some more webinars. And thank you very much for today and have a lovely rest of your day.